Okay, good evening, everyone. I am Lauren Gates, your host of tonight's Airway Health Solutions Conversation Series with our special guest and faculty, Dr. Kevin Boyd. Welcome, Dr. Boyd. How are you?
I'm doing well, a little tired. Big Wednesdays are long days for me, but
I know. Well, let's just dive right in. How many children did you have the pleasure of treating today?
well, between my partner, who is a primary care, what used to be called general dentist. We don't do that anymore. She's a primary care child and airway focused dentist, and she's wonderful. So between the two of us, Janet and I, we saw at least 60 patients, and that's kind of
Wonderful.
a typical day. We got five and a half chairs. We got one that we just use for impressions and things.
Wow. Busy, a lot of energy in your office. Well, I'm so excited to have you back. And I know anyone who hasn't seen Dr. Boyd before, we're going to put in the chat the link to our previous conversation, because just his bio alone, I think, took me 5 minutes or 10 minutes to read. So we both agreed earlier that we're not going to do the formal introductions tonight. But if you want to find out all about Dr. Kevin Boyd, he actually likes to be called Kev, but the kids call him Dr. Kevin. Is that right?
Dr. Kev.
Dr. Kev. And then you always correct me and make sure I call you Kev. So I'm not being disrespectful when I refer to Dr. Boyd tonight as Kev. That is his preference. So anyone out there can also call you Kev, I assume,
Please.
right?
Please.
Okay. Well, we're having you back because I've gotten so much interest, and I'm also curious about our topic tonight, which is early childhood expansive case reviews. You know, you did such a great job of laying the foundation with all the research that's out there, but everyone really wants to see what you do and see your work. So I thought it would be just a great night to really just focus on the treatment that you do so we can see the before and afters with our own eyes. But before we get started, what I'd like to do is just do a poll to see who we have in the audience. So let me go ahead, and you can go down and a poll should pop up, and let's see who we have with us tonight. And you can see that too, Kevin, right?
I can.
Okay, cool. Yeah, and I'm sorry, they only give me 8 choices, I believe. So describe what best fits you. And you can put in the chat if there is another profession that's not listed there. But you can see we have a nice mix here of professionals. And we welcome everybody because it's a collaborative, it is a collaborative outreach for sure. In fact, you're part of the Endeavor program, which I also recommend everyone listens to those webinars, which are recorded on the AAPMD website, which is aapmd.org. So welcome everyone tonight. Thanks for taking time out of your day. I know everyone gets a little sleepy now that it gets darker earlier. So thanks everyone for being here. But why don't we jump right in, Kev, and go ahead and share your screen, and let's get rolling and see the magic that you do and why you decide to begin as early as you do.
Great. And I'll say right off the bat, this is not rocket science. If it works, if a technique that's been used for 50 years, 100 years in medical and dental literature, if it would work on a 9 or a 12-year-old, guess what? It'll work on a 3 or 4-year-old, even some 2.5-year-olds. I'm going to show 3 cases tonight, but not before I get right into some questions that I'd like to ask you. And they're kind of rhetorical at this point. You're not going to have time to answer them, but I would tell you that you should maybe, take a screenshot of this and think about these questions. And we're not going to take time now, but maybe at the end or tonight's town hall, we can get at some of these. Now, these are 2 different patients, patient A and patient B. And, what did this one look like? She's 10. What did she look like at 3? And that's kind of, things I want you to look at, because I'm not going to deal with her. She's a geriatric patient in my practice, 10 years old. This is the oldest kid I have ever treated with this protocol. And it isn't just because of growth and development, it is attitude and parents and kids and hormones. And so I just love treating kids under 72 months old, under 6. And that's I'm the preschool curriculum advisor for Airway Health Solutions. That's I think Ben and Lauren sort of recruited me to direct the preschool curriculum for AHS. So this also, I'm going to go through some things that's in the literature that really says we should be doing this. Okay, this is not something that is experimental. There's evidence to support that certain malocclusion phenotypes, skeletal phenotypes, in all 3 dimensions, they will not self-correct. They are resistant to self-correction. They will usually become more serious, more complex, and either already are or will become comorbidities with sleep and breathing problems. It's not cosmetics. This is you will get cosmetic benefits from these treatments and orthodontic, conventional orthodontic benefits, but that's not why we do it. We are trying to optimize tongue space at the earliest possible age, such that the structure of the craniofacial respiratory complex is optimized for nasal breathing, habitual nose breathing while you're awake and you're asleep. That's why we do this. This is one kid that I'm going to feature. I'm just kind of, giving you a little preamble here of what we're going to be looking at. Some of you may have heard of the Bolton brush study that was done at Case Western from the early 1930s to the mid 1950s. It's the only longitudinal Case Western is where the Ceph was invented, the machine. And they did experiment, they took pictures of even newborns, Cephs, but they focused on 3 to 18-year-olds of children who they anticipated, based on metrics that they had in health history taking, of children that would probably not ever need orthodontics. And if a kid started at 3 with good spacing and wide palate, and they would put them in the study, but then by 5, maybe the mom died and couldn't breastfeed anymore, or they got taken out of the study. So these are kids that went from age 3 to 18 with pretty much ideal optimal occlusions. We don't say normal. Normal means average. Average used to mean optimal for health, but since 300 years ago, it's not. Okay. Well, these templates are what kids should look like at a given age based upon the Bolton brush norm. Okay. So that 3-year-old stand, that's where she was. I'm sorry, we just put this in today. Anyway, that template shouldn't be there because that's for a 3-year-old. They have them. This girl was 10, and I absolutely have a 10-year-old, and she's almost perfect now. That's where she was at 4. This took less than a year. So this kid here was 10, and what I wanted to put in there and put the wrong template in is that, you had to wait till she was 10? You kept her in treatment for 7 years? No. Look what she looked like a year later. We optimized that whole structure in this kid. So there's lots of literature that says that we should have a normative standards of values to look at kids of their treatment needs starting in the primary dentition. This is only recently published from Italy. Again, we already did that, sorry. So why do we do this? Why is this important? The face has evolved with the functions of mastication and respiration. Okay, so we should never separate out jaws, faces, and teeth without talking about the intimately connected airway. And this was, Dr. Johnson was head of ortho at Harvard in the 20s. And he was a fan of anthropology and really studied the evolution of the craniofacial respiratory complex. These are recent papers that have been written that says that if you expand a kid, you can improve their quality of life Look at and they have metrics, validated metrics for in general health, quality of life, general health, quality of life, just by doing an expansion on a transverse deficient patient. And you do not need a crossbite to diagnose maxillary transverse deficiency. Use the analogy to myopia. And again, one of the things I really want to get across tonight is you must start, if you recognize these kids, and hopefully a lot of you are at least identifying risk in the primary dentition, you pediatric dentists, and you primary care, what you used to call general dentists, but primary care dentists who see little kids, provide services for little kids. You should be screening these kids with validated screening tools, like the pediatric sleep questionnaire and like the CAS screenings form that we're developing at the ADA task force. An analogy can be made to nearsightedness. If you anticipate a parent might say, I didn't get braces till I was 13. Well, maybe they didn't know myopia. If anybody ever, I don't know what happened to my screen there. If an ophthalmologist would ever say, wait till a kid's driving a car before you give them glasses, that would be gross malpractice. Well, I don't say malpractice. I just say it's medically indefensible for any dental professional that sees a 3 or 4-year-old with a malocclusion that will not self-correct. And that's maxillary transverse deficiency with or without a crossbite. That is adenoid face, long face, lower facial height is really long. Again, they call it long face syndrome. That's not going to get better unless there's some sort of intervention. Mandibular retrusion or maxillary skeletal retrusion will not get better. You see a distal step molar in a 4-year-old, all you pediatric dentists and primary care dentists that see kids, and some few orthodontists on the call I see that might be seeing kids in the primary dentition. If you see a distal step molar, according to Dr. Sam Bashara, who taught me cephalometrics and growth and development at Iowa in the 80s, he did a longitudinal study from the Iowa growth cohort. Distal step molars will always 100% of the time remain a class 2. And if you start to work on it and at least optimizing transverse dimension, you're controlling sagittal. You can control vertical. They're a little more complex. Sagittal and vertical suboptimal development is not as it's much more complex to control in the primary dentition, but you still must do it. And I teach in a few different platforms, and I teach people how to do this. Transverse dimension is different. You can optimize it at 3, 4, 5, and 6 for those ages. I'll get into that later as we talk before we get to our cases. Okay, so this is the craniofacial respiratory complex. Don't say craniofacial anymore because it always involves a respiratory complex, if not the olfactory complex, the masticatory complex, the auditory complex. These are all survival mechanisms. That's what the anthropologists call these. So these are all in textbooks. This is a textbook that's about to come out. This started in the late 1800s, about 7 years after the end of the American Civil War, that this gentleman here, Dr. Bogue, he was an MD DDS. He only treated little kids under age 6, or that was the bulk of his practice. And he said, if you can't put a nickel between those primary teeth before age 5, you got a problem. You got a transverse problem. He called it 24 millimeters plus their age, starting at 4, at the mesiolingual or the palatal prominence of the upper second primary molars at the gingival margin. Should be 24 millimeters plus their age all the way up to 12 or 13. And that is very consistent with Dr. McNamara for the 6-year molar. He said you should be between 39 and 40 by the age of 12 or 13. We like to do it a lot sooner. These are literature. Some of you have heard me talk. This is nothing new. They were expanding kids in the primary dentition for nasal respiratory advantage, not to correct irregularities of teeth. And look at the titles of some of these journals. And this is Dr. Bogue. He did so much publishing on this. Not prospective longitudinal double-blinded studies, evidence-based, right? That didn't happen until after World War II, till they prosecuted Nazis at the Nuremberg trials. You can't experiment on humans, okay? But controlled observational studies are very powerful, and I quote them a lot. And I really get a kick out of, some orthodontists that say, oh, that's not evidence-based. Well, do you know the first evidence-based trial wasn't until after World War II, like 1945, and it was done on a tuberculosis drug. Anyway, more on that later. Early dental facial features of class 2 will not self-correct. This is Dr. McNamara group at Michigan. It will not self-correct. Once a class 2, always a class 2. This is a study done in Sweden by Linder Aronson. The orthodontists in the room know about Dr. Linder Aronson. He said that if you don't have a certain measurement from the most anterior point on foramen magnum to posterior nasal spine across the free airway space, if it doesn't measure at a certain length, you will have a mouth breather. It's going to be very difficult for that kid to turn in, and not all of them need their adenoids out. More later, but I've got lots of kids who have large adenoids, and guess what? We expand them, transverse expansion. And the paper from Audrey Yoon and Becca Bacow and others at Stanford that just came out talks about how transverse expansion will help the adenoid area normalize. And what they don't mention in that paper is the distance from the posterior nasal spine to the foramen magnum actually gets bigger because the entire maxillary complex will come forward in many instances when you just do transverse expansion. Okay, so those are the adenoid measurements that we measure. You'll learn that. Take it. And this is, get this paper, screenshot this. If you don't have it, ask Lauren, I'll send it to her. It's free access online. Anybody can download it. This is really important. Look at the anterior premaxilla pre-treatment, and look at you got some overbite here, and you had negative overjet there when you started. So this is why you've got to do this. This can impact airway. If you don't do it young, these kids are going to have shorter lives and they're going to have crappier lives. You can say that and take it to the bank too. The Dunedin study, Google it, Dunedin, Dunedin study from New Zealand, and hit self-control in children, health span and lifespan. And I can send you all that too. There's not enough time to go over that. Quality of life, we talked about, do the analogy with ophthalmology. It's a good one. It's a very solid analogy that you can make of why we should be acting early, as do developmental ophthalmologists act early. Okay, so here's our cases. Here we go. And you saw her in the first picture, the first slide that I showed. All right, that's what she looked like a year later. And that's what she looked like at 10 or 11. There's still more, she's like 14 or 15 now, and we're still doing things with her. But it's really not complex. And I don't keep these kids in continuous treatment. We get in and we get out. We call phase 1 orthodontics when it starts before the age of 7 or 8. We call it phase 1 part A, and we only charge half our fee. We get most of the heavy lifting done in about 14 to 18 months, seeing them about every 8 to 10 weeks, 6 to 8 to 10 weeks. Every kid's a little different. And then we guide them. We call it active retention until they have at least 10 permanent teeth. And then we do part B, and it's just double what the fee was 3 or 4 years previously. So it protects against inflation, I guess. Most parents really accept that. But if you're going to start really early, you're not going to keep them in treatment the whole time. You don't need, these tissues move so quickly. And these little kids, if you have pediatric dentistry behavior guidance skills, you understand child development, and the best kept secret in orthodontics right now is, guess what? Kids are hardwired to assimilate their parents' environment, their culture. If the parents are convinced that this is good for the child, just like don't cross the street when the light's against you because there's traffic coming. We know that children are hardwired to want to please their parents because we're here. We'd be extinct now if that weren't true. And once you try that out a little bit and you convince the parents and you show them the differences that can happen, they're going to want this for the kid, and the kid picks up on it. And don't get mad at them for non-compliance. Show happiness for any bit of compliance. And that is, I tell you, more kids would be treated if more orthodontists understood that concept. The orthodontic textbooks say, oh, in McNamara's textbook, we don't treat them at 4 or 5 because they just, at that age, they can't appreciate the importance of them complying. Well, no kidding. They don't. Of course they don't. Every pediatric dentist knows that. We have hundreds, if not thousands, of hours of experience, didactic and clinical opportunities to get really good at anticipating children's anxieties, fears, curiosities, and their parents. Orthodontists don't get 1 millisecond of training and behavior guidance in the American curriculum, probably all orthodontic curriculums. They don't teach it because you're not going to be treating them. In fact, you shouldn't treat them. That's the implication that's made. These are just what I do my consultations with. I always do a pre-treatment pediatric sleep questionnaire. A lot of these things cleared up, but there's always resistant symptoms. And there's other causes for these, but I'm taking off the table craniofacial respiratory structure. I'm optimizing that. I'm a dentist, and I tell them, oh, is this bedwetting going to go away? Is this apnea going to go away? I can't promise that, but I can minimize risk by optimizing tongue space at the earliest possible age and doing myofunctional therapy and doing release of tethered oral tissues when indicated. I don't do that, so I don't diagnose it. I assess risk. I use the Kotlow system. Every kid, I recommend myofunctional therapy assessment. If not treatment, that's up to them. And then I do a radiology report on everybody for their first visit. And the radiologists will highlight things, that mucosal thickening, sinuses, that the nasopharynx is occluded. And even some of them will say maxillary expansion is indicated. And when they do that, that's very helpful because a lot of parents will be resistant. You must anticipate why they will not accept your treatment. Be ready for that and be ready for answers. Okay. Those are notes from my myofunctional therapist. She keeps me up to date. This child did not have an adenoidectomy, but even if a kid has an adenoidectomy, who doesn't know that they will have recurrent symptoms? Almost always they'll get some degree. They'll be really good for a while, and then they'll get recurrent symptoms. It's a big problem. These are some, issues that happen with this child. I like this volume to be over 10 when I'm done with treatment. I like this minimum area to be 100 at least. And look at this, 67 minimum area. That's from back to front of the pharynx to 228. And this 3.7 went to 17. And this was all myofunctional therapy, no adenoidectomy. Look at that pharynx. Now, that's one point in time, but it's so consistent with other traits, behavioral traits that have changed. And this is the Linder-Aronson metric where we're measuring this adenoid 1, 7.81. That went to 18.46. We want it to be, that's a good number. That is a kid who has structure that will be conducive to nose breathing. This adenoid 2 superior measurement, 6.5, and it went to 13, so it doubled. You can reliably anticipate that there's going to be improvement. You don't promise, you under-promise and oversell. But I think the Yoon Bacow paper from Stanford, published in the journal Sleep, it's a very prestigious journal. Gimeno used to be editor of it. Look at the room for the canines. That's another thing. I always do the consultation in front of parents. Now, this canine width is usually between 7 and 8 millimeters wide by age 2. Okay, the crown is genetically determined. This is one of the few things that is completely genetically, not epigenetically determined. But the jaws, where those teeth have to live, that is epigenetics. That's a combination of genes and environment. Okay, I say when the baby's head comes out of the birth canal, it should say some assembly required on it, because it's not just going to grow like long bones do, like teeth do. Okay, Look at the distance between the unerupted distal of the lateral and the unerupted first bicuspid. These teeth are almost touching and there's overlap here. That is 100% that this canine will not have space. Well, that means they don't have tongue space now. And you tell them that. And then here's what happens with myofunctional therapy and expansion and breathing exercises and eating firm foods instead of mush. There's all kinds of things you can do to help these jaws grow. Some assembly required. Epigenetics. This is, the same child. You can look, the adenoids are still there. And they've even maybe gotten a little larger. But look at the distance. This is the Bacow Audrey-Yoon paper. It just shows this entire complex comes forward when you do transverse expansion. It's counterintuitive. Of course, we all know that the nasal cavity wides when you transverse expand. But who knew the sagittal depth of the bony nasopharynx? That's what Linda Aronson calls this. This distance from here to here is the bone. It's called the sagittal depth of the bony nasopharynx. Again, the Bolg index is just the upper second primary molar. And, this is her. The Bolton standards I talked to you a little bit about, but, with the Bolton standards, you can show a parent, this is where your kid's face should be. And these templates are this is a huge study, thousands of x-rays. Because Paul Newman, the actor, was a child that I don't know if he made it all the way through, but that could be an urban myth. He was from Shaker Heights, Cleveland, and that's where this took place. So I do these templates on everybody. So there she was at 10. Okay. And then we have a picture. We actually have a Bolton profile when she was 3 years old that I'm sorry it didn't show up, and maybe it comes up later. I did some last minute refining, as Lauren knows I do a lot. But you can see this and depth pellets. Just know from here, these pellets really don't often protrude up into the nasal floor. It's sort of an optical illusion because these alveolar walls are closer together, and the palate looks less deep when you spread that arch. Spreading the deciduous arch is how they used to refer to it back in the late 1800s, early 1900s. So see, now we still have a deep bite, right? But we have room for the canines. And she, this is, I think, at the end of phase one, or maybe this is pre-treatment to part B. Sorry, I don't have all the notes, but all this will be optimized in every dimension. Sorry. Okay. Here's our second patient. Now, obviously, she's maxillary deficient. Who doesn't, you can all see that. Look at where this upper lip should be. This is according to the Bolton norm. She was 5.5 when we started this anterior crossbite. And that's how she ended up before she was going into part B, when she had, 12 permanent teeth in, and we can start that. And look at that. I mean, I am so proud of this case. And the sleep and breathing problems that went away, she had a mess on her, all kinds of sleep and breathing problems. And look at this. I mean, these centrals this is called in-bone. Mariana Evans, who I do some anthropology work with at Penn, she calls this in-bone crowding. And that's another thing that Mariana has shown the literature that says, if you see lower anterior crowding, that is a proxy for maxillary transverse deficiency with or without a crossbite. Anterior crowding. Treating these kids early allows these permanent follicles to develop and erupt into, again, what Mariana calls juicy bone. They have much better periodontal health. Kids who get crowding resolved properly in an early age. So, and this is an extreme. Maxillary retrusion occurs in a lot of kids without being class 3. And again, I won't go into that too much, but that's something that was borne out from the Bolton study and also from the anthropology specimens that we looked at before the Industrial Revolution. Everyone is what you would call bimaxillary protrusive. Well, no, they were actually had jaws and faces that were optimal for nose breathing habitually for all their lives during sleep and wakefulness. This is really, I put reverse pull face masks just not on, not just class 3s. I put them on class 2s. I make the class 2 more protrusive, so the mandible can come even further forward. And I won't get into, this isn't a treatment course, but I do it, and it does have airway advantages. This kid's sleep immensely improved by improving that structure. And you can see all these yeses turned into no's, and all these things were resolving. So we say all no's, breathing all no's through the nose usually yields all no's on the pediatric sleep questionnaire. This is my last case, and he was just in yesterday. So we put this together in haste. In fact, we even had mom, they live a distance away, but she took a profile picture, so I could present this tonight. And he was 3 years and 3 months old, I think, when we started him. And again, the mom was just, so claps her hands at everything he does, and he just wanted to make her happy. So he wore this thing like a banshee. His face is bad. It's not too bad, but that chin, it's not going to get better. Chest is going to get worse. These are from the bowl, and I'll share these. Lauren, I didn't have these when we taught our last course, so I can give you a PowerPoint that people can use these, but I think I really want them to really know what they're doing, because it takes some finesse to do this. So anyway, this is what we found out on our initial exam. I am probably running out of my half hour here. So I just want to show if there's snoring or mouth breathing, it doesn't have to be both. According to David Gozal, that triggers more intense investigation of what's going on, and possibly even doing an overnight polysomnograph. So these are, what's going on here? There we go. So this is what we saw on his beam reader report. And I like beam readers. And this guy, Francisco Arasso, he's seen lots of my work, and he's looked at lots of kids' studies. He's got some proteges that he's training in this. So there's 2 or 3 people now that really are competent at little kids. Adenoid hypertrophy. These are things you should really, I make I call it a records consolidation. I make PowerPoint slides of all my intake diagnostics, and then I blow this up, and we do these on Zoom, and I explain to parents what all this is. High risk for obstructive apnea. How about it? And look at this, palatal expansion in combination with adenotonsillectomies. It's not up to me to tell them don't get an adenotonsillectomy. That's between them and the ENT. And I say, do not contact ENTs directly. Go through the child's primary care physician, which is usually a pediatrician. We have a note, dear primary care physician. It's a template. I'll share it with anybody who wants it. But it's just a way to, it's a way to really involve the primary care pediatrician. And it's a way to let them know you can do more than fill teeth. Or you orthodontists, more than just straightening teenagers' teeth. You know a lot more. And this is how you let these our collaborating physicians and myofunctional therapists and speech pathologists and all these people that we work with, they need to know that you are paying attention to this. The American Dental Association has pretty much declared, I don't know if that's the right word, that under the rubric of oral health, plaque-mediated disease, of course, gum disease and caries, airway health is now within, it's a shared domain. It's not our domain. It's not the ENT's domain. It's our domain. We share it with them. And then, I was going to talk a little bit about curvature spine and crowded out canines, but this is him. This is that little guy, that we started with, and he is doing beautifully now. So this is, in the lower is his yesterday, 2 days ago he was in, and just doing beautifully. So we got him into nighttime wear only now. He's not doing anything. He's doing myofunctional therapy. So That's really all I got, Lauren. This is a tutorial where I teach people in a course that we do for AHS. But, look at that adenoid. Okay, you measure that. And if you have an automage and ICAT, you can do this. So, okay, that's all I got.
No, that's amazing. And it's so, thank you for sharing your case. It's always so great to see everything that you do. And if some of the questions, we have a lot of questions, so I want to make sure that we can answer the majority of them. But a lot of this is, what is the youngest patient you ever treated?
Probably 2.5. I've got a couple of 2.5-year-olds that, and again, they were, one was a dental professional, mom was a hygienist. They moved to Tennessee, so I don't have follow-up. It's probably been 10 years, but he was doing beautifully. And then Anari, the little girl that you saw, she was just turned 3 when we started, and the parents were so motivated. But I routinely, I just feel I like under 72 months old. And I use that specifically because that's what the Academy of Pediatric Dentistry uses to define early childhood caries. So we sort of use that framework, early childhood malocclusion. And just like caries and gum disease, it won't self-correct unless you identify what the etiology is and remove those causes. Well, that's what we have to do with early childhood malocclusion, early childhood visual acuity. They don't call it that. They just see kids nearsighted at 4. You better fix it because it's going to get worse. Myopia gets worse without treatment. And there are neurological comorbidities with uncorrected, what they call refractive errors. And I talk a lot with developmental ophthalmologists, and they pretty much all think I've got a really good analogy here.
Can you talk a little bit, a lot of these questions that we're having tonight are about the how and your materials and your templates. And, I love the course that you put together, the 2-day mini residency. Can you just explain a little bit about that? Because I think that'll answer a lot of these questions, because you're not going to teach a technique course. You're not going to review all the templates and how to use them. That's why we put the course together. You want to just, in your words, kind of review. I know you're so proud of that course, and I am too, about what it is, getting your cookbook together, rather, to help patients people understand the techniques.
Yeah, I would, and I would say, it takes a while. There's a learning curve with this, and you're going to make mistakes. So what? This is how you're going to learn, and you're going to be helping kids. I mean, if an expander is in a kid's mouth and they're not turning it, but it's in the mouth, guess what happens to transverse dimension, from day one? Is that at the basal bone, it will grow, not like a long bone, but it will grow. But at the cusp tips, it won't grow. It won't grow. It won't get better. Okay. And that's from Harvard, 1945, in other papers that just say transverse dimension absolutely will not. Even if you just want to get to optimize the transverse dimension, you do not need a crossbite, but you need to validate it with metrics. And so, what did my friend Ben Moralia say? Is that the maxilla is the criminal, the mandible's the victim. If you get the maxillary transverse right, you're helping a kid. And if that's all you want to do, in a way, a posterior crossbite's a blessing, because even some very conventional orthodontists, okay, yeah, fix the crossbite, but it's just, you need to be able to defend yourself of why you're doing this. Tongue space. You are optimizing tongue space at the earliest possible age, which sets the stage for optimizing mode of respiration. Nose breathing. Air is not air. There's so much information on the deleterious systemic health effects affecting rate of aging. People age faster who don't sleep well. They don't. Again, Google the word self-control, impulse control, and Dunedin study, Dunedin. I didn't have time to talk about that, but I will, I think, in Savannah, is that kids live longer have better self-control before the age of 11. Guess who has better self-control? Kids who sleep like crap or kids who sleep well? Okay, so, that may seem like a broad brush stroke or a giant leap, but it just isn't. So I don't want to go like, what expander do you use? Well, I got about
Right,
6 different kinds,
exactly.
and it depends on the kid. It depends on the
Yeah,
kid.
so I know a lot of these questions are exactly those type of questions. I'm trying to stay high level, so I don't want people to think that we're ignoring them. But a lot of these technique questions just do not have simple answers, and that's why you developed the technique course that you did an amazing job. So let's go to some of these more of the high level question is, do you encounter problems with family physicians when discussing tonsils and adenoids?
Yeah, and for me, again, you just emphasize this is a shared domain. If it's above the clavicles, it's in our domain. It's not ours alone. It's in the sleep, respiratory, ENT. We all need to work together the way they did 100 years ago. Okay, so I have a few ENTs that actually refer to me. But it took a while. That doesn't happen overnight, and it takes communication. And remember, most of you on this call, you've got experience, and obviously you wouldn't be taking time out of your day to be listening to this or watching it unless it obviously made sense to you, but you haven't always been this way. I know you weren't this way when you were in dental school because they don't teach it in dental school. So just remember where you came from. Don't be judgmental. It's frustrating when they don't know what you know, but you haven't always known this. And that's a way to talk to them. And if you can get them to talk to you, I don't know. We can think on that together because I haven't necessarily solved it, but I do know I made some inroads by just remembering where I came from. I'm in my 12th year of doing this. So I don't know. That's the best I can answer for that.
No, it's great. Can we reduce tonsil size in children by sealing lips and becoming a nasal breather?
Well, here's and this is what Audrey Yoon and Kushida and Bacow, their paper from Stanford. If you've not seen that paper, ask for it. And Lauren, I'll send her a PDF. Everybody can get it. They said that by expanding 8.5-year-olds, that the tonsils and adenoids shrunk. Don't say that. Optimized. That they normalized. And they, improved nasal breathing is one thing that they tested for. They didn't do sleep data, but this was a really good pilot study, and it's going to lead to a lot more. And if it works on 8.5-year-olds, guess what? It works on a 2.5-year-old. So go figure. 20 teeth is all you need to get an expander in. 20 teeth, and that's usually somewhere between 2.5 and 3.
How can we request, in quotes, from an orthodontist to expand more than what the 8mm attained with the traditional RPE?
I would say you can't, and don't even try. It's not, it's sort of like, this is what they've learned. It's hard to unlearn things. You all know that. There's stuff you've been resistant to learning. The best way to engage an orthodontist is, again, we'll learn on this together because I'm still working on it, is that, hey, you've done a great job with this expansion that you've gotten. The kids got more tongue space, but there's some things I've learned. Can I share them with you? Would you read these? And, some of them will be honest with you and say, you know what? No, I won't. I'm fine with where my result is. Then it's up to the parent to make a decision, and that's all I can tell you. Good luck.
How do you approach the parents of asymptomatic pediatric patients with crowding?
That crowding, and again, is it up and down? Is it, upper crowding doesn't really become obvious right away. Lower crowding tends to show up first. If you have no space between the primary teeth by 5 years old, you got crowding. You have in-bone crowding. You have lack of canine space. Don't be afraid. Again, radiation safety. I have an iCat Flex. It's a 4.8 scan, and I've got videos that parents can watch about if they have fears about ionizing radiation. I have no qualms in taking an iCat Flex quick scan on a 3-year-old. But you have to be comfortable with that. It's such a great teaching tool. It helps the parents understand if there's no room for the canines to erupt when they're 12, that means they don't have tongue space now. So I just, I don't know. I talk to parents and I try to anticipate what their resistance is going to be to what I'm going to recommend and try to allay their fears with evidence. And not just evidence from scientific literature, but evidence from, I've got a huge library now of cases longitudinally at different stages of treatment. And I have a list of parents that, oh my God, my kid's doing better in school, blah, blah, blah. If you ever need a parent who's doubtful because they themselves were, I would be, please put me on the list and we will talk to them. Lots of different things. You'll come up with your own ways. And again, no offense to the guys here, but pediatric dentists, we deal mainly with female adult caregivers, and they have something that men don't have. 2X chromosomes for sure, but maternal instinct. We have an instinct, but it's nothing like what a woman has for her child. And I just sort of try to tap into that. And usually, and if there's one dissenting parent, it's usually the dad. I didn't get braces until I was 13, then we're not ready to treat because the kid will pick up on the strife and you will not have a cooperative patient. So let it take time. If I got a 3-year-old that I know I can fix and nobody's going to be on board till they're 5, so I wait 2 years, it's better than waiting until 9. And that's what I tell people. Be flexible. Don't feel you have to do it because it can be done. And you will learn what you can do. And people get overloaded when they come in, and it doesn't happen much anymore because most people know about my practice and what they're doing because they do their due diligence. And a lot of the pediatricians, know my work, and the otolaryngologist, the myofunctional therapist. But if I what we call just moved from Oakland, right? And
Dr. Cav, you
they live
just
near
blocked
my
out a
office.
little bit. Can you just repeat what you just said?
Well,
It just-
if
it
I
just
have
faded out a little bit.
a garden variety pediatric dental patient that's coming in for a checkup and a cleaning, and then I start talking about no space between the teeth, no tongue space, tongue tie, tonsils are, oh, I thought you were a dentist. What does bedwetting have to do with dentistry? From the PSQ. And that really doesn't happen anymore, but you need to anticipate that this can overwhelm parents when they come in. So it doesn't happen so much anymore to me, only because they're coming here intentionally because they know what I do. And that'll all happen with you. When you start getting a few of these, kids under 6 years old, that you fixed them and helped them. And if nothing else, you're a dentist. Don't ever say anything else. I am a dentist. I am not an orthodontist. I'm a pediatric dentist who does exclusively orthodontics. I don't drill teeth anymore. You tell people that, but tell them about your specialty if you're a pediatric dentist. Tell them about your specialty if you're a mom. I'm a specialist in my child. I come up with something new every day, and you got to have a couple of people on your staff that really know how to get into a child's world and how to help the parents understand how this is in the best long-term health benefit of their child. It will yield cosmetic benefits, but it is not why we do it. It is not, it's tongue space. It's all about tongue space, habitual nose breathing and tongue space.
What age do you take the CBCT? What is the youngest?
Well, you saw one tonight, 3 years old. I mean, I'll do it. And you know what? There's something called a scout where you just line the kid up. We've got that to where 2, 3, 4-year-olds and the parents are reluctant, even though I can give them, the safety information. I can do a scout. It's about the same radiation exposure dosage. And it's about a millisecond. And we can crisp it up, and I can even trace them. I can do a cursory self-tracing on them. And it always shows adenoids. So if I refer a kid with a pediatrician to an ENT, I will send that along. If it's a 2.5, 3-year-old, they have to sit still for a millisecond, and I don't charge for it. It's free. Okay. So, but if anybody in your town, in your area, or if you have a radiology service, look for an iCat FLX Flex. It is the best machine on the planet in terms of giving high quality imaging and very low radiation exposure time and dosage. You get a
Do you
panoramic.
take alginate impressions, or do you use
No,
digital scan?
we just bought the new iTero today. There's a much, oh my gosh, it even takes photos. So I don't represent iTero, but all the money I spent on that thing, and we've had it for 6 years. And the new one came out, and they bought us lunch today, and that thing and they'll buy you lunch. You don't have to buy it, and see about this new iTero. And it works on 3-year-old. I mean, it looks like it's really big. Well, the handle is, but the little one that goes to the mouth, and it's got a 45-degree angle, so it acts like a cheek retractor, and it goes a lot. This new one goes faster, so the kids don't have to sit as still. But sometimes, boom, quick alginate. I got the chrome colored things, and then once it turns white, boom, and I got to keep it in there for 12 seconds. And I'm a pedodontist. Crying doesn't bother me. They get over it faster than the parents do. So I still have to do alginate sometimes.
Okay. What are some suggestions? I know you have a whole section on the course on this, but to calm down anxious kids, anything you can give, like a nugget for tonight?
Well,
to calm down.
One is, for older kids, not geriatric patients. Like that's 8 and 9-year-olds. Those are geriatric patients in my practice. But for the 4 and 5-year-olds that are older and they want to be combative, hey, honey, don't worry about it. You don't have to do anything here you don't want to do. If you don't want to open your mouth, but mommy can just take another day off of work, and then I leave the room, and mom will say something to him because she doesn't want to take another day off of work. Or you just, but the older kids, 7, 8, they want to be combative. Hey, guess what, brother? Dr. Kev doesn't fight with anybody. I never fought with a kid. You know why? Because so many little kids have beat me up, and I don't want to get beat up. And that usually cracks them up or disarms them. And then you just leave the room and leave them with the parent and let them. But in my staff, they'll do things. It's not a one-person job. It just is. You have to have a team, and part of your team is the parents.
What is your opinion on sleep studies, the home sleep studies, PSGs for children? There's so many questions around that. Can you summarize your overall?
So I'll do it real quick. Overnight PSGs, and it's a lie detector test. You know that? If you take the somno out of polysomnograph, it's a polygraph. It's a lie detector test that tests sleep things. Somebody just told me that. I was like, wow. Anyway, they're burdensome. They cost a lot of money, and their kids not in their own bed, and they're hooked up to all these wires, and it's one night, so it's really pretty advanced. It's usually a kid that's already got some other medical complications or whatever. I don't get involved too much with it. And I have 2 of the largest pediatric sleep centers in the world in my hometown. And I know I do research with both of the heads of sleep medicine at the 2 biggest hospitals, but very seldom do and I don't refer for sleep studies. Who do I call? The pediatrician. Hey, I'm seeing some stuff here. Do you think we should, maybe an ENT first, allergy? I don't know. But the ring, the sleep image ring, oh my God, I am so impressed. I was just at a meeting in Arizona and saw the most brilliant discussion and demonstration about the little kid ring. It's cardiopulmonary coupling, and we actually are applying for a grant because we want to do a study for some of the kids that I'm working with. Darius Logbani, he's the head of sleep medicine, he'll be in Savannah, right? Darius?
Yeah, we're talking about, when you keep referring to Savannah, we're talking about the Airway Palooza that we're hosting.
Yeah.
Everyone, it's going to be amazing. I know you're looking forward to it. I'm looking forward to it. A lot of people on this call are attending, so we look forward to having you. It's not too late to register. And yeah, why don't you tell us a little bit about that, Dr. Boyd, while we're, you know, basically your part of it and why you're so excited to be part of Palooza.
Well, one thing is that there's curious people, there's experienced people. They've done some of Ben's courses, and if you don't know Ben's stuff, you totally get mine. And Darius is going to be there. And Darius he's a sleep medicine physician who, how did I ever get along without dentistry? He really respects what we're doing so much, and it helps him in his work. That's the way I feel about myofunctional therapists now. How did I ever get along without a myofunctional therapist? But it took a while. I thought it was voodoo at first, and I just takes a while for some of this stuff. So no, I'm just to see everybody. And my wife, actually, the first time in 10 years, is going to come with me to a CE event.
Wow, I can't wait to meet her.
I know she
That's
loves,
amazing.
Savannah and Devil in the White City, or no, what was that? What was that book about Savannah? There's something really, The Devil Wears Prada, I think it is. That's it.
Oh,
Anyway,
okay.
no, I can't wait. There's lots of reasons I want to go to that.
Lots of good stuff. But before we go into the updates, another question is, what percentage of children have airway problems?
Well, almost 100% of everyone I see, but
Mhm.
they're coming there for that. And they say 2 to 3% of children have apnea. Well, apnea is an end-stage disease. Okay, a lot of these kids have antecedents to apnea, and I don't know what the percentage is. I don't know if that's published. I really should know that, and I will look for it. But when you say 2 to 3% of children have sleep apnea, do you know how many children there are in America? I mean, that is a huge number, 2 to 3%. And kids with antecedents to apnea, and what do ENTs do? They take out tonsils and adenoids. What else? Or nasal steroids, maybe a deviated septum. This is a treatment. If nothing else, you're going to make subsequent orthodontic intervention much less complex. And that's all you you diagnose sleep problems, you recognize risk factors, you assess risk, but you don't diagnose. I don't even refer kids to get their wisdom teeth out. I get them to be evaluated by the oral surgeon. I don't take out wisdom teeth, so I don't diagnose. I don't diagnose tongue tie because I don't do lasers. I assess risk and I refer them to the myofunctional therapist. The more people you can get on your collaborative team, the more successful you're going to be. You're going to reach more children, and you're going to you just won't have the dead ends. This was a rough start. It's going, I'm going fast and furious. I mean, there's just lots of people seeking this now, but man, when I started, oh God, and I was butting heads with so many people. People, the orthodontists that used to challenge me, you're starting too soon and you're using up the orthodontic benefit. It was all fiscal. And I'm not saying every orthodontist did that. That just doesn't really, that's not a big situation anymore. I've got good relationships with some, or at least non-negative relationships with some orthodontists that don't do this. I've even had a few refer to me. So go figure, it's changing. It's changing.
I know we're coming up to the top of the hour, and I know we have a lot of our Airway dentists, our alumni on the call. So please be sure to join us on our town hall, which is immediately following this conversation. And that's one of the perks of becoming an alumni, is that we have these quarterly town hall meetings where we get to kind of roll up our sleeves and dive into a little bit more nitty-gritty conversation. So for those Airway dentists, we will see you shortly over there. But what I do want to do is just make sure that we have time to kind of review what's going on at Airway Health Solutions. So I did want to go ahead and share my screen just from the beginning. This course, I know Dr. Boyd, we both worked together countless hours on this to really make sure that everybody, I just want to make sure everyone can see this. Let me see. There we go. Okay. It's a 2-day course, and it's a live option, and it's right on the ocean in Pompano Beach at the Marriott Pompano, which I know you're going to love, Kev. I was just there. So we have the ocean view from the convention center, which is really nice. And what I'm really excited about this is you really share how you do this, your techniques, the appliances, all of your templates. You share so much literature. So this is a really must-see course, in my opinion, if you're going to treat children under 72 months. So there are many pearls to learn from this. Is there anything you want to add, Kev, about this course? Because I know that you really, you put so much work into it. Anything you want to say about this?
If people have specific questions, I mean, when Lauren said we work countless hours, you have no idea how much, she helped me and collaborated with me with her skills as a coordinator. And so Lauren can probably field a lot of the questions, but if not, she could triage them and get something to me beforehand if you're on the fence of whether or not you want to invest time and money. And, it's a big commitment. But, that's all I can say.
Well, I think it's worth it for sure. Let me just go to the next slide here. We have our adult mini residency, the last one of the year with Dr. Ben Moralia. If you're interested, it's not too late to sign up for that. We have a couple spots left, and then we'll kick off with this pediatric mini residency early February. And I know, Dr. Boyd, you took his mini residency, and you actually recommended that you take that before you take your mini residency. So thank you for sharing that. I'm just trying to go.
Well, that may seem counterintuitive to people. Why would you take a course on treating older kids before you would treat younger? And that was really your and Ben's idea, and I love it. At first I thought, the 8 sequence, but no, if you can do what Ben does in older kids, you just scale it back and do it younger. And you can see, in older kids, Ben's treating 6, 7, and 8-year-olds too. But I'm just saying that if you see what you're fixing in his course, you don't want the kids even to get as bad as they are when they get to him at, say, 7 or 8 years old. So
right. Wonderful. And then Dr. Moralia also has an advanced course. So that's the older teens, and also learning bracket and wire techniques with the expansive techniques. Dr. Gelb has his course coming March 31st. So it's around the corner. It's sneaking up on us. So mark your calendars. It's not too early to register. You can check that out on our website as well. We're actually excited to have a peer-to-peer course specifically for orthodontists to learn from Dr. Brett Christensen. He's going to just talk about how he does pediatric or airway orthodontics, but general dentists and pediatric dentists are invited as well. And here's the Palooza, which actually it's around the corner. It's just coming up December 9th and 10th. And you probably recognize a lot of these people, but it's going to be really a celebration of the airway dentists and the collaborative care of the road less traveled. So we're really happy to get everyone under one roof with our keynote speaker, James Nestor. I'm sure you've all read Breath by now or heard of Breath. If not, it's a must read and a must share book with your patients. So again, it's not too late. And we do have a code in the chat with Dr. Boyd's VIP link. And also this is open for all allied health professionals. So everyone's welcome to attend. So go to our website and you will get an exclusive $500 discount for the allied health professionals. Here are our sponsors. We thank them very much for being part of this journey with us. A lot of people talk about that they want to do myofunctional therapy, but they don't have someone nearby. So we do provide telehealth oral facial myofunctional therapy through Brittany Sierra Murphy. So reach out for us if you're interested, because we don't want this to be a barrier to care. All of our experts who's on here, they all recommend myofunctional therapy. So reach out to myofunctional therapists, and all my myofunctional therapists out there, look at our doctor locator. I encourage everyone to go in there now and look at all these green dots near you that you can collaborate with. Okay, because they're looking for you. And if you can get in-person care, even better. So we're a little dry here in North Dakota, South Dakota, Nevada, and also South Carolina. So hopefully that'll change after the Palooza. But the more green dots, the more opportunities there are for collaborative care with the oral facial myofunctional therapists and other allied health professionals. And we're really excited. We have a global presence as well. So check out our locator. Once you take our mini residency, then we add you on that locator because Airway dentists are looking for you. We do have our Airway aligners right now. I know, Dr. Boyd, you reached out to us about that recently, or Orla did anyway. So we're really proud of this because it's Dr. Ben Moralia's algorithms built in. So all you get is an expansive case. You don't have to worry about any hidden retraction or intrusion. And you're eligible for that, again, after you take one of our courses, just to learn the philosophy behind all of the appliances. So we work with Ohlendorf Appliance Lab. So we want to thank Kevin for being our partner in that. If you have any questions, you can reach out to him about some of our Airway Health appliances. And we encourage everyone here to join our Airway Dentist Facebook group who has taken our course. It's a private group. In fact, we're going to log off and jump on pretty soon with our town hall, another perk for becoming an Airway dentist. And if you don't, if you're not a dentist or just want to be part of our general community, you can join our Airway Health meetup group. That's open to everybody. And our next conversations are coming up. We have January 18th, Dr. Michael Gelb will be demystifying TMD, and Dr. Shireen Leem will be Breathe, Sleep, and Thrive, her new book. So we're really excited to have them to kick off the new year. Tomorrow, if anyone's interested in medical billing, we have a free webinar that'll also be in the chat where you can register for that. If not, you can go to our Facebook, or the link is here if you want to copy that. It's a free CE, get one CE and learn all about what's new in medical billing from our partners at Nearman. So we thank everyone. I can't thank you enough, Dr. Boyd, for your time after your long day. But I think you've opened up so many eyes today and just gave everyone the confidence to march on because they can. And I love how you say it's not, how did you describe it in the beginning? It's not rocket science.
It really
certainly
is
seems
not.
like it, but
Yeah, it's just not. But you've got to get the parents on board. If the parents aren't ready, the kid will never be ready. And you must really just try to anticipate what the resistance would be and why they're that way. And if you can't provide good evidence, if they don't see the conviction in your voice, in your eyes, they're not ready. That's all.
okay. Well, thanks again. And if you want to learn more, we hope you join us in January to learn Dr. Boyd's techniques. We'll see our alumni over at the town hall. You need to log out and log back on to the town hall invite. Dr. Boyd, we're just going to send that over to you real quick so you have it fresh in your inbox. And for everyone else, we will see you hopefully at the Palooza, but if not, we will see you in January. My goodness. All right. Well, thanks everyone for your time. As always, it's a pleasure. Thanks, Kev. We'll see everyone.
Okay, you're welcome. Bye all. Thanks for coming.
Bye.
Bye.